Thank you very much, Dr. Ellenbogen, and it's a real pleasure, and I'm most grateful to be here representing the ATLAS study investigators to share with you our findings today. Tricuspid regurgitation in the general patient population is associated with an increased risk of mortality, and this association is dose-dependent in nature. From this data, we see that in over 30,000 patients, severe tricuspid regurgitation is associated with a 50% 5-year mortality. Importantly, even mild tricuspid regurgitation is associated with a higher risk of death than the absence of or trivial tricuspid regurgitation. Now, tricuspid regurgitation following the implantation of transvenous cardiac leads is a well-known and recognized phenomenon. However, its incidence in the literature varies from between 7% and 45%. Importantly, this evidence is observational in nature, and therefore, the extent to which the natural history of the underlying cardiac disease for which the device was implanted accounts for the tricuspid regurgitation after implant is not clear. Therefore, our objectives were firstly to determine the effect of a transvenous implantable cardioverter-defibrillator on tricuspid regurgitation severity. Our secondary objectives were to determine the effects of the transvenous ICD on right ventricular size and function. To accomplish this, we performed an echocardiographic analysis of the Avoid Transvenous Leads in Appropriate Subjects, or ATLAS trial. ATLAS was a randomized controlled trial that compared subcutaneous ICDs with transvenous ICDs, and it was conducted at 14 Canadian sites. This investigator-initiated study was funded by Boston Scientific through an unrestricted research grant, and Boston Scientific did not have any input into this analysis. ATLAS's inclusion criteria: to get into the study, patients had to have an indication, either primary or secondary prevention, for an implantable cardioverter-defibrillator. In addition, they were younger than 60 years of age or had to have some other risk factor for a lead-related complication, such as a cardiogenetic phenotype, need for chronic hemodialysis, prior lead removal for infection, prior heart valve surgery, or chronic obstructive pulmonary disease. Patients were not eligible for ATLAS if they had a contraindication to either type of ICD, if they had a mechanical tricuspid valve, a previous Fontan repair or intracardiac shunt, an indication for pacing, ventricular assist device, a PR interval greater than 240 milliseconds, or were pregnant. This slide shows the design of the trial. Overall, 503 participants were randomized to receive either the subcutaneous or transvenous device, and we had evaluable baseline echocardiographic data in 248 subcutaneous ICD recipients and 249 transvenous device recipients. Echocardiography was repeated at 6 months following implant, and we had echocardiographic data available in 90% of participants. Importantly, echocardiography was performed according to a standardized protocol, and the baseline images were acquired before device implant and again at 6 months follow-up. Echo data were transferred digitally to the core laboratory at the Population Health Research Institute at McMaster University, where cardiologists, investigators who were blinded to the allocation group, performed echo analyses. Importantly, masking of the actual leads, which were visible in echo images, was not feasible. The primary endpoint of this analysis was tricuspid regurgitation, which is classified as none or trivial, mild, moderate, or severe, and the secondary endpoints were the right ventricular basal diameter, right ventricular fractional area change, and right ventricular function, which was quantified as normal, mild, moderate, or severely impaired, and the evaluation of RV function and tricuspid regurgitation were based on all of the available echo data. This table shows the baseline clinical characteristics of the study population. We see that the average age was approximately 50 years, about 1/4 were women, and 1/3 had a history of coronary artery disease. Just over 1 in 5 had a history of dilated cardiomyopathy, and just under 1 in 5 hypertrophic cardiomyopathy. 4% had right ventricular cardiomyopathy, and about 1/2 had a history of heart failure. About 1/3 had hypertension, and 1 in 5 diabetes. This table shows the baseline echocardiographic characteristics. On average, left ventricular systolic function was mildly impaired. Just over 2/3 had either no or trivial tricuspid regurgitation prior to device implantation. Just over 1/5 had mild tricuspid regurgitation, and about 5% had moderate or severe tricuspid regurgitation. Right ventricular fractional area change was averaging at about 41%, where 35% or less is consistent with definite RV systolic dysfunction. The average right ventricular diameter was 38 millimeters, which is at the upper limit of normal, and about 3/4 had preserved systolic LV function, 10% mild RV impairment, a further 10% moderate RV impairment, with a smaller proportion with severe RV impairment at baseline. This figure shows the proportion of participants with no or trivial tricuspid regurgitation in blue, mild tricuspid regurgitation in red, and moderate or severe TR in green or yellow, respectively. On the left of the slide, you can see that in the subcutaneous device group, tricuspid regurgitation from baseline to 6 months tended actually to improve in severity. In contrast, in the transvenous device group, we see that tricuspid regurgitation tended to worsen. The group time interaction p-value was less than 0.001, indicating that these patterns and trends were highly unlikely to be due to chance alone. Amongst the subcutaneous device recipients, 26% had mild or greater tricuspid regurgitation at baseline, and this decreased to 19% by 6 months. 5% of this group had moderate or severe TR at baseline, decreasing to 2% at 6 months. In contrast, in the transvenous ICD group, 32% had mild or greater tricuspid regurgitation at baseline, and this increased by 6 months to 42%. 6% of this group had moderate or severe TR at baseline, and this increased slightly to 7% at 6 months follow-up. These data translated to an odds of worsening of tricuspid regurgitation of 7.2 with 95% confidence interval of 3.3 to 15.8. This figure shows the proportion of participants with normal RV systolic function in the blue parts of the columns, mild impairment in RV function in red, and moderate or severe impairment in green and yellow, respectively. We found that in both groups, there appeared to be an improvement in RV systolic function in general between baseline and 6 months, and we did not find evidence of any difference between the two groups. This graph shows on the vertical axis the right ventricular fractional area change. Consistent with the data on the previous slide, we see that in both groups, fractional area change tended to increase from baseline to 6 months, and again, there was no detectable difference in RV systolic function or its trajectory between the two groups. And here on the vertical axis, we see RV basal diameter, showing that there was no difference between the two groups or their trajectories from baseline to 6 months. Unfortunately, one of my slides appears to be missing, but what we have done is a subgroup analysis to determine whether the effects of the transvenous lead on tricuspid regurgitation severity varied according to baseline left ventricular ejection fraction, RV size, RV function, or the presence or absence of baseline tricuspid regurgitation. We did not find any evidence of heterogeneity, and so the effect of the transvenous lead on tricuspid regurgitation was consistent irrespective of those characteristics. So in conclusion, the findings from this analysis of the ATLAS trial were firstly that there was a 7-fold increase in the likelihood of worsening tricuspid regurgitation in recipients of a transvenous lead as compared with a subcutaneous lead. And this was accompanied by a 7% incidence of moderate or severe tricuspid regurgitation in the group receiving a transvenous lead at 6 months follow-up. ATLAS is a unique study because it is the first study to systematically evaluate changes in tricuspid regurgitation in a randomized trial of patients receiving a transvenous device as compared to a subcutaneous device. And longer-term follow-up is needed to define what the impact of our findings is on right ventricular size and function, and most importantly, on clinical outcomes, including heart failure. Thank you very much for your attention.